Organizational Structure and Models of Care, a look at a Level 2 Trauma Emergency Department, created by Christina Bright, Nursing 406, Leadership and Management in Nursing, November 10, 2019. Introduction. As we all know, healthcare organizations, they are built in a hierarchy that is commonly referred to as the chain of command. The chain of command is a level of leadership down to employees, and basically, this hierarchy allows employees to know how they fit into the overall purpose of the organization. So in order for them to know how they fit, the organization must have developed a standard process of communication, and that way that connects the employees to the right employer or manager, leader, etc., so that they know the right person to go to in times of need with questions, with anything, comments, concerns that they have about what's going on in their work environment. The organizational structure can be affected by goals, strategy, environment, technology, and organization size. The larger the organization, the larger that hierarchy or chain of command is going to be. Also, we're going to be talking about models of care, specifically in the emergency department, because that is where I work, so that is what I am presenting, and why it's necessary to achieve the most efficient quality of care, and how we utilize appropriate resources to promote safety and optimal patient outcomes. Models of care, they are always being revamped and analyzed, altered to achieve the best goals, and that is a constant thing that we always focus on in the emergency department in order to get the best throughput, patient satisfaction, and like we said, the most optimal outcomes, efficient care, quality care, safety care. All those components are part of what we look at and the goals that we're trying to achieve. Relationships among components of the organizational chart. So the top of the mark for us as far as in the emergency department goes, and this is excluding the CEO, the VP, the vice president, all that, the actual president. This is just going from the nursing standpoint for us. So we're only starting with the chief nursing officer, and we're going to go down through all the staff members that they are responsible for. It is important to note that number one, we are all in the same team. Knowing how to utilize leadership resources and how to appropriately navigate that chain of command is absolutely pertinent when we're working in healthcare. Also, it is also important to know when it is appropriate to jump that chain of command, or, is it never appropriate? So from my opinion, I think there are times where the chain of command has to be jumped, and that's just the way it falls. So situation, as a nurse, let's say I'm having an issue with a team leader. Well, my team leader is technically in my structural hierarchy. That is my next in line that I would go to if I had an issue. Unfortunately, if I'm having a problem with the team leader, I'm going to have to jump that team leader because I'm going to go to my nursing unit supervisor, because they oversee that team leader, and that's who I'm having an issue with. So there are times where I think it is appropriate to jump, but how far you jump is all going to depend on that situation. And you need to be wary that jumping that chain of command can also ruffle some feathers. So, you just need to know the appropriate times to do that and how high you go with that jumping. So communication is key. Without communication, we would definitely fall apart in our structural healthcare world. It is pertinent. It is absolutely a necessity. So this is the organizational structure chart that I created. It's a visual of actually my ER, like I said, starting with the chief nursing officer all the way down to where I am, which I'm considering at the bottom, I guess, right now. So the chief nursing officer is our number one head honcho in our ER. Below that, you come to the director. We actually have two types of directors. So the first director this one is above all the mission health emergency departments. So this is our main one, as well as all of our sister emergency departments. They are the head honcho. So then you come down to the mission main campus director, and then from there you go to our managers. We have both day and night shift. That goes down to our nursing unit supervisors, to our team leaders, and down to the registered nurses, the ER techs, and the unit clerks. And all of these fall under that one chief nursing officer. So how do we communicate? So there are multiple communication levels that are employed within the healthcare organizational structure. Commonly used, interpersonal, group, and organizational communication. So the interpersonal is basically you and one other person. That could be me and my team leader, me and my manager, just you and one other person coming together to have a conversation. A group is 3 or more people. 3 or more people can be team nursing. Some places do that and do groups of 3 or more together. They help relieve lunches, they help watch patients, or they team nurse in a sense of they all take care of the patients together instead of one separated. So that could be a group. And then there's things like organizations. So these tend to be groups of people more than the small group of 3. This is a larger group of different skills that come together, but they're trying to achieve the same goals. So, for instance, in my situation, we have an emergency department nursing governance. This governance council is all of our nursing team members are permitted to go to this, to offer their opinions, to offer their ideas, and to also pose some problematic areas that maybe they're trying to reach out for other people to come in and say, hey, here's a solution. So those kind of groups are great because it takes all different skills to come together to find a common goal and the best goal that we can resolve issues. So barriers to communication. A communication barrier is anything that prevents us from receiving and understanding the messages others use to convey their information, ideas, and thoughts. This is a huge problem in every workplace, especially nursing. We have so many communication barriers all the time, and that's not just between, interpersonal communication with other staff members, but we have patients, family members, everybody else who comes through that we could have issues with, and there's a plethora of issues that can cause those barriers. So some barriers that we face. Number one, I put this on here, is that we need to all acknowledge that we face barriers in communication. Nobody is devoid of this. Everybody at some point is going to have a communication barrier within their workplace, within their life. So we just need to acknowledge that this is something that happens. So some of the barriers that we face are gender, cultural, age, religion, attitude, and just insufficient knowledge. So gender is a common one. Between men and women, we in general just have difference of opinions. We are built differently structurally, we think differently, so we can always have some barriers just on that. Sometimes that gender falls under the cultural little bit too. Different cultures place different genders and different hierarchy levels even within their family component, their cultural component. So some men are seen as important or the decision makers, and so that could be a gender difference just within culture. But culture in general, we just need to be aware of and know that we are all different. We come from different backgrounds, different histories, and it doesn't make anybody better than the other. It just makes us different, and we just have to acknowledge those differences, respect those differences, and try to, maybe learn and understand them a little bit too. Ageism is a thing between the young, the old, the middle. We all come in different generations. Different ages bring about different experiences, different life choices, different styles, almost different languages, just with the slang and terminologies. And then, of course, we're down to religion. We just need to respect and understand that people have different beliefs. They don't have to be the same beliefs as us for us to have good communication, but those could be some barriers that we face. Having a good attitude versus a poor attitude, and then just insufficient knowledge. Newer nurses just do not know the same things that experienced nurses do, and it is a barrier. It's something that will be able to go over, they will be able to hopefully get over and learn from. But these are reasons why there can be some hard times in communication. They just don't know how to appropriately, efficiently communicate what they need to communicate. So how do we fix it? What we can do for better communication. So we can become an expert listener. When you learn to listen, you will learn to have better understanding of what is being communicated. There's the old saying, be quick to listen and slow to speak. When you can do that, you're going to retain a little bit more of what that person is saying. You're going to have a better appreciation and understanding of what they are trying to communicate, and that is going to help prevent some communication barriers and breakdowns that occur. Be very simple and concise when you're communicating, and refrain from overuse of slang and colloquial terms. Those can be really hard, the slang and the colloquial terms, because people do not understand what they mean, and different cultures who are having trouble just learning English may have trouble with that slang terminology. So just be really simple, brief when you're speaking to someone, get your point across. Be very tactful. That way there's no error or room for communication. Remain culturally aware and understand your own biases, and work to improve your own perceptions. So just know that, as we stated before, there's different cultures, people have different beliefs. We just need to acknowledge that we're not all going to believe and understand the same things coming from different backgrounds, but we need to be open-minded in accepting and learning those differences, and how we can manage to get through those together. Keep a positive attitude. How you portray yourself has great impact on how others will perceive you, and that is 100% true. A better attitude is always going to be perceived better than a poor attitude. So this is the standard emergency room model of care. This goes through our input, throughput, and output in the emergency room. Basically, it discusses how people get to us. They show up in our ER. So they're either coming in privately in their own vehicle, or they're coming by ambulance. Either way, the patient arrives to the ER. So we are going to triage them. We are going to triage them by using our ESI tool, which is our emergency severity index. It goes 1 through 5, 1 being the worst, 5 being the least emergent. And from that point on, they're going to be placed in an appropriate room for that level of ESI that they are assigned. They're going to be evaluated, assessed, provided the appropriate treatments that they need. And then from there, we are going to come up with their disposition. So they are going to either be admitted, they are going to be transferred, or they are going to be sent home, or to possibly an outsourced service such as long-term care. It just all depends on the patient. There's that small number that does leave without being seen due to their own time constraints or their inability to wait. So that is also a possibility, but this is the typical ER flow and how it works. So ideas for the improvement of the model of care. So the biggest need for the model of care is education. I think we can do a better job of educating the public about the appropriate times to come to the emergency room. Not everything is emergency room worthy. That's why we have urgent cares on the outside to see patients that can get in a little quicker and get out a little quicker as well. The other thing that I had come up with was placing strong staff and triage for application of appropriate ESI level ranking. I think you need experienced nurses out there to do that. They're going to help the flow and help everybody move a little quicker and more efficiently, because they're able to look at patients and understand how sick and their needs at the same time. So they're going to be better at placing those patients in the appropriate rooms than a lesser experienced nurse. Also creating an urgent care area within the hospital for quick in and out visits. So our ER is really working on that right now, kind of having a really quick in and out urgent care area to where we can get those patients seen efficiently and appropriately and have them not, be there for so long. So it's really great for them and it's great for us because we can kind of get them in and out. And then it's better follow-up with discharge patients in need of primary care providers. It's really important that, we really get with people and reiterate the importance of having that primary care who can follow them as needed. So in conclusion, an organization's chain of command details the importance of transparent and effective channels of communication between effective leadership, management, and employees. And understanding the levels of managerial communication will help the organization develop a communication standard. So knowing that is the most important. We need to know who our leadership, who our management is, as well as they need to know how their employees fall under them. And that helps just with that chain of command and that hierarchy of leadership and management. With proper organizational structure, the facilitation of decision making and conflict and resolution should be attainable. So with that structure, it helps us in resolving those problems and resolving those issues by going to those right leaders and managers that are above us. And then having the model of care provides proficient quality care and safety in patient care. It acts as a tool and a visual for processes of patient care from its initiation through discharge. At least that's how it is for us in the ER. That is how our model of care works. It lets us know exactly where the patient's coming from and the process and how they're going to get there, and then how the disposition of home, transfer, or inpatient is going to be achieved. This is my reference page, and I thank you for listening.